Thank you. Only half of that is true. Thank you for the invitation. As myself and Ian Flock from Tigerberg was our second invitation here. 2 years ago as well in Malawi. We had a wonderful time, and it's just so nice to be back here and share our experiences. So, I want to talk about the challenges of providing advanced spine care to underserved communities in Southern Africa. And my disclosures, I've got no disclosures. So firstly, Namibia. It's just down the road from here. It's a big, very vast country with only 2.5 million people. So the logistics of moving people around with spinal problems is always a big problem. You've got 2.54 people per square kilometer. That's a very, very vast area. Namibia is, like Botswana, also famous for something, and that is our high accident rate, MVA rate. So we're dealing with 45 deaths per 100,000. That is the highest in the world, and we'll go into that a bit later. So, Namibia has got a beautiful desert. Firstly, as Scott mentioned, I'm a fellowship-trained spinal surgeon. I train in South Africa, and you get to spinal surgery via orthopedics or neurosurgery. And these days, they recommend that you actually do a spinal fellowship because the basic training in orthopedics and neurosurgery is not these days not adequate to deal with the pathology we see these days. In litigation, you need extra training in spinal surgery. And I would like to share some of my experiences of being in Namibia and try and sketch the challenges of the third world and setting up a spinal service there. So, how do we define advanced spine care? What exactly does that mean? Does it mean it's complex procedures? Does it mean you do computer-assisted navigation? Do you do microsurgery? I often get requests from overseas, from Switzerland, Germany, and say, oh, they'd love to come into an outreach and come here. And I say, well, come and you'll see our facilities. If you don't have your O-arm and all your advanced imaging, it's very difficult to offer the care you do in Europe, in Africa. And without sounding arrogant, spinal surgery is advanced. There is no light option where you can, do a smallish procedure at a smallish hospital. And the reason why is because even a simple procedure like a biopsy, if I do a biopsy from the neck and I put my needle in the wrong place, I hit the carotid, the person can bleed to death. They have the esophagus, they get esophagitis, and they can die from that. So the complications of any basic spinal procedure is actually massive, and you need to be able to think of that before you embark on a program in a smallish area. In Namibia, we just went through the birth pains of setting up a spinal service, and after 5 years, this toddler is kind of learning to walk, but still falling a lot. And at minimum, if you want to set up a spinal service in a third world country, you need to have a couple of things. You need a screening program. And the problem now is that I see every week massive amounts of patients to my back clinic that could have been screened by healthcare workers, nurses, physios, chiropractors, community helpers, and that I don't see every possible problem just in my spinal outpatient. Because 98% of people do not need surgery, they do not need a spinal surgeon, they need good habits, they need to stop smoking, they need to lose weight, they need to do yoga, they need to do all kinds of non-operative management options before you dive into surgery. Access to MRI scanner. This is so important to making your decisions. If you don't have an MRI scanner, you cannot make a diagnosis. That's really very difficult to treat advanced spine care. You need a dedicated spinal surgeon. So you need somebody who's driving the surgical side. And so without a spinal surgeon in a country, you're going to struggle to have all the tiers of spinal care. In theatre, if you don't have a C-arm to screen, you cannot confirm your level, you cannot put in implants, you cannot do anything. You need a C-arm. So that's a basic thing you need. Okay. Operating table with good light. Without good light, you can't do that. You need a microscope. You need implants. I know Tira had a lot of frustrations here with getting implants into the state system, and I understand his frustrations. That if you don't have equipment, you cannot do the surgery. And it's then better to do no surgery than to try and do it with the wrong equipment. You need anesthetic doctors. You need senior anesthetists. They need to keep a certain blood pressure, otherwise people bleed to death on the table. You need high care. You need those beds. And unless everybody gets on board, you cannot offer advanced spinal care. Rehabilitation facilities. What do you do with patients once they're out of the surgery? How do you rehab them? How do you monitor them? What do you do with spinal cord injury patients? So Africa is in a way similar to Namibia in that the private sector, and Namibia has got the best, but it serves the minority. And the equipment in my private hospital, not mine, but the hospital I work at in Namibia, the equipment, the microscopes are similar to what you see in America and Europe, and it's really first world care. But the state and the public and the government sectors serve the masses and have really got the worst equipment, they've got the short end of the stick. But despite this, in Namibia you find Oshakati, in Sophomoon, in Walvis Bay, in the state hospitals. And I see the same here in Botswana. You've got excellence, islands of excellence in a sea of need. So there's so much need, but in some areas people have really tried very hard and made massive impacts. So there are also a lot of good things about the service. In my outpatient that I see in Namibia, in Windhoek Central Hospital, every Wednesday I've got a spinal clinic from about 8 until 1 or 2 o'clock, and I see 35 to 50 new patients every week. If you see a new patient with spinal pathology, you can't just rush through it. You've got to look at MRI scan, you've got to look at blood results, you've got to teach as well. So there's no way you can adequately yourself see all those people. I've got one medical officer, one intern helping me. I see 2 to 3 new TB patients every week. Now I was going to get stuck on this TB thing for a while, and that is that we know we've got pulmonary TB, and people who've got pulmonary TB, 2 to 3% of pulmonary of TB is extrapulmonary, so it means somewhere else, and it can be musculoskeletal. And if it's in the musculoskeletal system, then half of it is in the spine. So if I'm seeing 2 to 3 new TB spines a week, just imagine if you extrapolate how many pulmonary TBs are walking around. So TB is a big, big problem, and the surgical care of that is massive. Pathology I see in Namibia is very similar to here. TB, trauma, tumor, the 3 Ts, and then your normal degeneration, back and neck disease. As I said, it's very difficult to screen all these patients adequately in a little morning clinic with 35 to 50 patients. The irony is the waiting list to see me in private is 3 to 4 months in my private practice. But go to the state hospital and you can see me within 24 hours. And this is not good. It's just because a person walks to the trauma unit with back pain and say, don't worry, you'll see the spinal surgeon tomorrow. So I'm seeing a lot of things that should have gone through the channels of physio, chiro, exercise, normal 6 months conservative treatment before you dive into x-rays, blood tests, MRIs. So that whole system doesn't exist. That concept of conservative management is just bang, you see the surgeon the next day, and that overloads me with dealing with things that should have been dealt with comfortably in the community or anywhere else, and then I cannot focus on the serious pathology. So, in the state, we often work under shocking conditions. That's just my theatre. Sometimes it's 29.9 degrees Celsius. It's very difficult to offer good surgery there. It's uncomfortable for the patient, for the doctor, for sepsis. So, bad conditions, broken lights, aircon not working, screening machine intermittent working. So, there are a lot of complaints, a lot of problems. On the other side, in a private hospital, 2 kilometers away, I can do almost any procedure I'd like to do. I've got the best implants, I've got the best everything in one town, 2 kilometers from each other. It's actually very, very sad. So, trauma. We spoke briefly about spinal cord trauma, and motor car accidents are massive in Namibia. And we've got car accidents, people driving with animals, pedestrians, interpersonal violence, tourists. All these cause big spinal cord injuries, and they are a massive burden of disease for the country financially. And we see high energy accidents, and people are at the scene of accident, people lying there waiting for to be taken to hospitals, and the roads are actually very good, and the cars are okay, but there is a bad driver attitude, and people just overtake, they're impatient, and people usually die in these accidents because they are such high energy accidents. Animals on the road. This car wasn't in the car before the time, it wasn't a passenger, ended up there. So people hit things on the road. A few weeks ago, on a Sunday morning, I get called by the doctors, oh please, there's a knife in the back, what can we do about this? So this is kind of spinal pathology we see the whole time. And this is where our kind guests from the USA and from Europe, tourists and rollovers. So you get a car accident, you can hit another car. Or you can hit a kudu who jumps in front of you. Or you drive too fast on a gravel road with a 4x4, most tourists, and think when you start skidding in the corner, you hit the brake and you roll over. So we see a lot of rollover accidents of tourists in our country. Another example here, 52-year-old female, high-speed car accident, delayed her treatment, 2 weeks. They had a CT scan in this town of this neck, and for some reason, the education level there was so that they thought we would watch this patient for 2 weeks as opposed to referring it. So these are the things we're dealing with. People arrive with complete spinal cord injuries, for 2 weeks, treated conservatively. Okay. So what are our challenges regarding trauma? Well, we've got the vast distances. The accidents happen often in rural areas. There's no national emergency call number. You can't just phone 10111 and report accidents. People often wait 3-4 hours at the scene of accident before they get found. Often the initial care is poor. You know, there's programs like ATLS it's not common in Namibia. Closest hospital cannot deal with these damage injuries, and often a transfer is 5 to 10 hours to the next big centre. Then, going away from trauma, TB. I see TB every week, as I said, and it often gets referred to as compression fracture. A guy fell out of a tree or fell over, and for 3, 6, 8, 12 months gets treated as a compression fracture, and no one thinks so far as to say, is there any constitutional symptoms, any red flags, anything suggests that this could be TB as well. Another example, 80-year-old male, and in my red flag talk, I'll talk about this as well, but in a nutshell, this guy's 80 years old. He went to see his primary healthcare doctor or clinic with urinary retention, and they inserted a catheter and sent him home. And 4 months later, with the catheter, he comes back and says, I'm still not better, but now I'm on crutches, I'm falling around. And he then got seen by our state hospital in Windhoek. They did x-rays in the orthopedic department. They said x-rays were normal, and they sent him home again. If you're sending someone 18 years home with a catheter permanently and with crutches, you know, somewhere the light's got to go on, you know, this needs further referral. Anybody except the floor can guess what that was? Hydatid cyst disease. Inococcus. Accidental host. We'll talk about that later. Again, we see what you guys see as well, tumors, missing pedicles, and these things often get missed. Okay, also got world-class animals in Namibia. Okay, so what are our challenges to finish off? For non-trauma, so we've got no prevention, no screening program, and that's why we say World Spine Care, please, what you've done in Botswana is amazing, please come to Namibia. We'll organize it. We'll get our Minister of Health involved. We'll get to whoever, but we need you guys to come and create a program. Ignorance is bliss. Okay? If you as a doctor see a person a few times, 80 years old, with a catheter for 4 months, walking with crutches, and you think that's normal, that's terrible. Spinal cord injuries with dislocations, being kept for 2 weeks to observe them, to see if they get better, when there's proven dislocation. You know, I'm sorry. The poor inter-hospital transfer system boils down to distance and money. Rural versus private. You're private, got everything, rural, got nothing. We need to balance it out. Time to MRI scan in the state, 3 months. In private, tonight. Time to theatre in the state, 3 months. Private, I can do it tonight. So, despite all the constraints, there are some good news. There's some good news in Namibia as well. The first thing is, in the last 5 years, we've set up this comprehensive surgical spinal service in Windhoek. And we've got backup from Ian Flock and his team from Tygerberg, who come every 3 months and they help us with some of the cases. Ian is also training some of our neurosurgeons, so we've got in the pipeline people coming, so help's on its way. It's going to take a few years. I started a biopsy spinal service, and this I would see as advanced spine care for rural areas. And this service, I think, is a big step forward, because at least now we know what we're dealing with. You know, there are so many TBs and MDR TBs, XDR TBs walking around, tumors, infections. And if you can't biopsy a spine, then you can't get to the diagnosis. So we do that regularly. Every list, I've got 2 or 3 patients I'm just doing biopsies on. So any TB that walks my door, any tumor, anything gets a biopsy immediately the next Thursday. Motor Vehicle Accident Fund, for some reason, functions very well compared to South Africa, and we've got the resource to move sick patients all over the country with aeroplanes. If I say this guy is very sick, fly him, they'll fly him to my hospital, and we can treat them. And the cost of treating a spinal cord injury initially well is much cheaper than dealing with a paralyzed person for the next 20 years. In the last 3 years, we also had a big drive to train ATLS, trauma, orthopedic spine care. We're running courses, workshops, and hopefully the level of initial care gets better. We've increased the ability to treat acute spinal cord injuries well, treating retraction, teaching on cones, manipulation, while they're waiting for surgery. Then the spinalis rehab team is here from Sweden. The system they started here in Botswana in 2012 works wonderfully, and we copied that, and they came to us, and they gave us the same gift, and it's still going well. We've got a very nice group of caring nurses, physios, and a rehabilitation program that functions well, and we're very lucky to have that. We've also got a WhatsApp group in the country with orthopedics and spinal surgery, and people can immediately WhatsApp their picture, ask for advice. Unfortunately, patient confidentiality goes out the door because every X-ray's got the name on, etc., etc. But it's doing more good than bad, and I think I can immediately identify problems, say send it now, don't send it. Once the patient's been worked up in the periphery and gets to Windhoek, I think the care is generally good. But often people don't know these have to be referred, or they get referred late. And that is the big problem. And then this myth, I don't want to step on toes because we're all trying to improve this country and every country, but that myth of advanced surgical spinal care in rural areas is maybe unrealistic. You need to centralize your surgical care, not the advanced spine care, but the surgical care to a one big center where you've got all the help, ICU, MRI scanners, everything. But going out to a smallish area and doing advanced surgical care in the periphery, in my opinion, we're not there yet. So, thank you for your time.